Hello, we continue with the worms or with the helminths. We have studied the flatworms so far, both cystodes and trematodes, and we shall go to the roundworms. The roundworms are referred to as the nematodes, and they are commonly referred to as the geohelminths because they are closely associated with the ground, generally, like you shall see in the subsequent slides. Okay, you see here that they are associated with the ground, with agriculture, with rural areas, with underprivileged areas. They are wide spread in the world, all over the world, with different densities, more common in tropical areas and less common in the subtropical areas, and farther north they would become less common as well. Those roundworms are round in cross-section, bilaterally symmetrical, variable size from 1 millimeter, very small, to 1 meter. Organs are made up of a cuticle on the outside like a skin, a durable skin on the outside, a digestive system, a nervous system, excretory system. They have got muscles that allows them to move well, and the sexual organs. They develop by molting, shedding, which is shedding the outer cuticle and enlarging from one stage to the other. Generally, they have got separate sexes, and the female is larger than the male. Reproduction and development usually from the embryo and the egg, referred to as L1. They go through 4 molts to reach to the adult stage, which is L5. Okay. Some names of those medically important nematodes, the bowel nematodes. Those are worms which occur within the bowels, inside the bowels. We have Enterobius vermicularis, Trichuris tricura, Ascaris lombricoides, Ankylostoma duodenale and Nicator americanus, and Strongyloides stercoralis. Those are luminal parasites, luminal nematodes, and we shall go over those in a little bit of detail, have an idea about their life cycles, and we start with the Enterobius vermicularis, which is the pinworm. It's so called the pinworm because it is quite small, actually, about 1 centimeter in size or slightly less than that for the adult worm. They are fairly common in the world, and the transmission is by the fecal-oral route. That is, the eggs are expressed in feces, in the stools of humans, and they embryonate rapidly in the outside environment to become infective to other humans as well. The life cycle is very simple, fecal-oral, like you see here, and you can see in this drawing the adults, male and female, living in the small intestines. The female is larger than the male, and the male has a curved spicule at its tail. All right. Clinically, mostly asymptomatic. However, they may rarely produce symptoms of anal pruritus. Now, anal pruritus or itching in the perianal area is more common in children. Adults can tolerate that fairly well, apparently. Vaginitis may occur very rarely in a young girl if the adult female pinworm migrates into the vagina and upwards into the pelvis sometimes. It may produce vaginitis. This is rare. Diagnosis. Less than 10% of those eggs are found in the stools. That is, the stool examination is not useful or may not be useful. A better test would be to look for the eggs in the perirectal area. Why is this so? Because usually the adult worms go out from the colon to the perianal area, perirectal area, and there they deposit the eggs and they disintegrate or die. So the eggs are in the perianal area, and this process probably contributes to the irritation and itching of the perianal area. Okay, hence we can look at them and we can find them by the perirectal swabs or cellophane tape slide or a sticky paddle. The simplest thing of these would be to take a scotch tape, stick it to the perianal area and mount it on a glass slide and look for the characteristic eggs like you see here under the microscope. And you can see them. It's elongated, more flattened on one side, it's transparent, and a very small egg. Now the size can be measured easily under the microscope. Treatment: mebendazole, and eradication of infection by treating the rest of the family, everybody in the home, and repeating the treatment in 2 weeks. Now, hand washing is very important, so we have got to keep that. Why do we repeat the treatment in 2 weeks? Actually, because the eggs embryonate rapidly in the outer environment within the household, and they remain viable for about 2 weeks. So you treat initially, and then 2 weeks later you give another treatment. It's 1 tablet of mebendazole, and that will eradicate the infection, hopefully, together with hand washing and the cleaning the house as well. All right. Trichuris trichura, the whipworm. It's so called because its shape, 1/3 of it is thicker than the other 2/3, hence it looks like a whip, the whip with which they whip the horses that would be pulling on a carriage, and the characteristic egg, you see it there as well. Now, Trichuris trichura, or the whipworm, again is mostly asymptomatic, but heavy infection may produce diarrhea, dysentery, anemia, and rectal prolapse. Those are rather rare findings, and they correspond to heavy infection. Diagnosis is by examination of the stools, by standard techniques to find the characteristic egg. And the egg is like you see here. It is brown in color or brownish in color. It has got 2 polar knobs, one on each side like you see here. Sometimes it's said that it looks like a lemon or a barrel shaped. It's neither like this nor that, but fairly close to that. Treatment: mebendazole or albendazole. Ascaris lumbricoides, the roundworm. Now, this is the roundworm of man, and it can be as large as 30 to 40 centimeters, male and female. The female is larger, and you can see it collected in picture in a dish in here. And here, this is the roundworm of humans. And the roundworm has got a similar life cycle to the prior 2 worms. It's by the fecal oral route. And you see a vegetation drawn on this slide. It's closely associated with agriculture and farming in rural areas. One interesting feature is that the lung here is drawn is painted in red, colored in red actually, because Ascaris lumbricoides, the roundworm, has got a pulmonary phase. That is, during its development, it passes through the lungs for a day or 2 maybe. During that time, it will produce a transient asthma-like picture, asthma, with eosinophilia. If you take a blood test, you may find eosinophils, and that would correspond to Loeffler's syndrome. That would correspond to Loeffler's syndrome, characterized by transient asthma and eosinophilia, like you see here. Okay, Ascaris, well, this Loeffler syndrome is not very common actually, but more commonly encountered in areas where the roundworm is common, like in rural areas, agricultural areas. Here in Beirut, we don't see much of that, but in the area of Tripoli, where the rate of infection with Ascaris, the roundworm, is high, doctors may see it more frequently than we do here. Clinically, little symptoms. However, if the worm moves around, it may obstruct the bile duct. Heavy infection may produce obstruction of the intestines as well. And the worm may migrate to produce some irritation here and there. It may come out at night through the nose or through the mouth, or through a surgical anastomosis after surgery. It can all happen, but it's rare. And clinically, it's less significant, less important. It is well tolerated. Diagnosis is by stool examination to find the characteristic eggs, and the treatment is mebendazole or albendazole. Now, those are the characteristic eggs of Ascaris. It can be, it may have like knobs on the surface of the eggs, like you see here, or it can be smooth actually. It is characteristic in every feature, like you see here. Slightly elongated, and the size is fairly well known. It is brownish in color and characteristic. The hookworms. The hookworms, Ankylostoma duodenale and Nicator americanus. They are so called the hookworms because they hook themselves up to the small intestinal mucosa, like you see in this picture. And like you see also, like the mouth, the big mouth of Ankylostoma duodenale, this is a very enlarged picture. It has got teeth-like structures to help it attach to the intestinal mucosa. And the other one, Nicator americanus, similarly have got similar blade-like structures that help it to attach. And on the right-hand side, you see blood on the mucosa, and this is at the traumatized site of the attachment of the hookworms, and hence heavy infection may result in significant blood loss on the long term and iron deficiency anemia. Okay, the life cycle here is similar to before, except that infection is acquired not by the fecal oral route, although the eggs are deposited in the feces from infected people, but the eggs hatch out actually in the external environment, and the rhabditiform larva comes out of the egg, and then it transforms, it molts once in nature into the filariform larva. This thin filariform larva is so suited to penetrate the skin of the feet. So when people tread into wet areas where infected stools have been deposited, the filariform larva would have the chance to penetrate the skin to produce infection again. And it may produce the ground itch like you see here. If you look at this child is wearing something in the feet, but other children would not have anything, and stepping into those areas may produce infection. Like you see in this African family, all of the children are barefooted here, and they can easily acquire hookworm infection. Actually, hookworm infection is closely associated with refugee camps, with slum houses, and with underprivileged area, poor areas. Clinically, usually asymptomatic again. The migratory phase is rare. We don't notice Loeffler syndrome with it, no. Heavy infections can cause, as I said, blood loss and iron deficiency anemia. Malnutrition from protein loss as well can occur in children, and most of those children in the underprivileged area may have malnutrition anyway as well. Diagnosis is by stool examination to find the ova, the egg like you see here, and the egg is again characteristic. It's a transparent egg with a thin egg shell like you see here, and it usually houses a multicellular ovum like you see very well. However, if the stool sample is left aside in the laboratory for a few hours before examination, the larva may hatch out of the egg, and you may be able to see the larvae. So finding larvae in a stool specimen, those could be the larvae of hookworms. So we have to be careful and to characterize them very well to identify them. And this is easy for the parasitology technicians. It's not difficult at all. Treatment, again, mebendazole or albendazole. Here, let me say that we have luminal infections within the lumen of the intestines. So the drug which is better suited, mebendazole, is less absorbed, it's older and it's cheaper, but it's very well suited to use for these worms. Albendazole is better absorbed, and I don't need a drug here that is better absorbed because it's not a tissue infection, it's a luminal infection only. So for those worms that I have told you about this lecture, I would be satisfied with mebendazole, which is cheaper and readily available. If not, I would go to albendazole, of course. Then we go to Strongyloides stercoralis, a step higher in the complexity on those roundworms. It's referred to as the threadworm. it tends to be thin and elongated. It has got two specific characteristics here: auto-infection and hyper-infection. Auto-infection and hyper-infection. Now, the auto-infection results in the infected person in the sense that if the larvae of these worms, if they come out to the outer skin in the perianal area around the buttocks, actually in the buttock area, then they may molt once and transform from rhabditiform to filariform larvae and penetrate the skin again. So they have got this capacity of auto-infection, and it's important, and this is probably the explanation for long-lived infection for tens of years, whereas the worm itself may live for few years only. And then hyperinfection occurs by auto-infection, but especially in the immunocompromised patients. Hence, the larvae will be penetrating the skin, but not being checked or killed by the immune system in immunocompromised patients, and hence hyperinfection may result. This is specific to Strongyloides stercoralis. Okay, transmission of Strongyloides stercoralis is again by penetration of the skin of the feet in nature, in outside environment. However, it has got some other characteristic, a non-parasitic life cycle in soil. So if it does not find the appropriate host to penetrate its skin, then it can go on with its life cycle, molt further, and develop into adults in nature. This is a non-parasitic existence for preservation of the species. Auto-infection can occur like in mental institutions, where the larvae are deposited on the outside of the skin, and if those patients, like in shelter houses, and so if such patients are not cleaned well, then there would be auto-infection, and with immunocompromise, hyperinfection. Now, gram-negative bacteremia or meningitis sometimes may result because of the penetration of these larvae eventually into the blood vessel, and they would carry on their surface some of the microorganisms of the colonic flora, mainly gram-negative Enterobacteriaceae. Diagnosis. Well, the diagnosis by stool examination is okay. You can find the larvae of Strongyloides. Okay, the larvae of Strongyloides. This is larvae paras, actually. It produces the larvae. However, you need concentration techniques and other things. Duodenal aspirate can be done sometimes, and it can be yielding. However, serology probably is the most helpful, because microscopy does not give a good yield, so serology can be very helpful. One clue to the infection is the presence of moderate eosinophilia in the range of 10 to 30%, and I shall mention it to you later as well. Culture of stools, of course, on the agar plates, and then you find that with the growth of bacteria, you feel like there is a worm that is disturbing the culture, leaving traces behind it. So it can be as well. Berman concentration of stools has got a better yield. This is one of the methods of concentrating the stools to find eggs or larvae. It can be also used, and it can be helpful. Treatment. Here the treatment is ivermectin, and if not available, then the second best would be thiabendazole or albendazole. Here we don't have ivermectin in Beirut, so we usually use albendazole because thiabendazole is not readily available as well. Problems: diagnostic techniques are not very sensitive, and serology, I would say again, is usually the most helpful. Okay, so we have studied those intestinal nematodes. Now you know Trichuris, the whipworm, Enterobius, the pinworm, and in the small intestines we have got Ascaris, the roundworm, Strongyloides, the threadworm, and Ankylostoma and Nicator, the hookworms. This is like a review for you. Then, under the intestinal nematodes, a general message: diagnosis is usually by stool examination for the eggs in most of those cases, except for the pinworm, for example, where the Scotch tape test or looking for the eggs in the perianal, around the perianal area, would give a better yield. and rarely you would find the larvae of these worms, like in Strongyloides, of course, you would find the larvae. And the hookworms, as I told you, the eggs may hatch, and the larvae of the hookworms can be found by microscopic examination. Treatment, generally mebendazole or albendazole, or in the case of Strongyloides, it's ivermectin. Then we go to the tissue nematodes, which means that those are the roundworms which produce infection in the tissues of humans. Let's see how that occurs. And let me just sound to you some of the names: Trichinella spiralis, Toxocara canis, Ankylostoma species, Dracunculus medinensis, and the filarial worms, which we will come to study later. So let's start with these. Trichinella spiralis. This is the agent of trichinosis. I'm sure you may have heard of trichinosis or trichinosis. Here it occurs in Lebanon because there is the habit in some families of the consumption of pork meat. Now this pork meat, if it contains the infection and if it is raw or not cooked well, then it may produce the infection. And how do people acquire the infection? Infection is acquired by eating pork meat, as I said, which is raw or undercooked. Let's go to the life cycle. Here you can see it in the lower left-hand side. You see the sylvatic cycle. This is a very common infection in wild animals, and it may involve any wild animal actually, like you see here. But if we come to the domestic cycle, people acquire it mostly from pigs, through pork meat, ingestion of pork meat, as I told you. Now, how do pigs acquire the infection? It's by foraging around and eating an infected animal like rats and mice. So if the pig farming is not well hygienic, then they may have access to carcasses of rats and mice, and they may get infected themselves. So, and the meat of slaughtered pigs, if it is not inspected by inspectors in slaughterhouses, then the meat may contain the infection, the larvae of Trichinella spiralis in the muscles, and this may produce infection in man. Now, in man, actually, as people ingest the infected meat, within 1 month, there will be abdominal pain and diarrhea. Why? Because the larvae are liberated in the intestinal tract, and they penetrate the intestinal mucosa, producing irritation in there. There they would be molting and developing further, and by this irritation of the mucosa, they will produce abdominal pain and diarrhea. So this is limited to the first month of the infection. And then in the midterm, after the first month, when the adults would have matured and they are roundworms, separate sexes, male and female, and the female starts depositing its larvae, it's interesting that at the time it will come to deposit the larvae, it sticks its tail next to a capillary or a lymphatic channel, and like it injects its larvae directly into the bloodstream or the lymphatic channel. Hence, they go into the circulation to be deposited anywhere in the body. They go mostly to the muscles, actually, including the muscle of the heart and the muscle of the tongue, and they may go ectopically to the central nervous system as well. So, midterm, after 1 month, the patient would have muscle pain and weakness, facial and peripheral edema, and swelling because of the inflammation in the muscles and the subcutaneous tissues, with a rash that may develop, sometimes encephalitis and myocarditis whenever they come to involve the brain or the heart. Long term, after months, the infection quiets down, it subsides. Usually it becomes asymptomatic despite the presence of the Trichinella larvae within cysts in the tissues and in the muscles. So this is for trichinosis. You notice the edema in the face of this patient, especially in the lips and around the eyes. The whole face is slightly edematous. The splinter hemorrhages under the fingernails, and there you see on a pathologic slide the Trichinella spiralis cysts where the larvae are encysted. We say they encysted within the skeletal muscles like you see here. And sometimes we refer to them as cocoons, يعني مثل الشرنقات, as cocoons in there. Okay, we go on with the diagnosis of trichinosis, clinical picture with general laboratory support, of course. Eosinophilia is a clue to the diagnosis, and raised creatinine or creatinine phosphokinase from the muscles, the CPK from the muscles due to the inflammation in the muscles. Those are clues to the diagnosis, laboratory clues to the clinical diagnosis. Microscopic examination of a muscle biopsy, because that's where the symptoms are, that's where the pain is, will show us the larvae within the muscle tissue. Rarely serology is needed, and it is helpful as well, but rarely requested. Again, here we see the cysts of the Trichinella spiralis larvae within the muscles. On the right hand side, you see the larva within the cyst, and the pericyst is infiltrated by white BCs, as indicated by the presence of many dark dots which correspond to the nuclei of the white blood cells which have come to the area as part of the inflammation. And over the left hand side, you see those white BCs invading the cyst and killing the larva in there. Treatment is mebendazole or albendazole and steroids. Why? Because there is a lot of inflammation, and as you kill more of those cysts, there will be more inflammation as well. So steroids are needed as non-specific anti-inflammatory agents. Problems: education of the meat consumers and lack of good drugs. And I would add to this actually lack of hygienic pig farming. Pig farming has got to be in hygienic places actually, and the animals have got to be well raised and well taken care of. And also the importance of presence of central slaughterhouses. This is where animals are slaughtered and the meat can be easily inspected. They will simply get a small piece of the muscle of the slaughtered animal and crush it between two glass slides, put it under the microscope, and you can see, like you see here in this slide, the encysted larvae of Trichinella spiralis. In the upper panel, we have light infection, the lower panel, heavy infection. Hence, the meat will be classified as non-suitable for human consumption. And if ever, it has to be very well cooked. Otherwise, infection may be transmitted. Then we have got Toxocara canis. Toxocara canis, this is the roundworm of the dog. So how come that we are studying it in medical parasitology, which concerns humans, human patients? Actually, Toxocara canis can produce visceral larva migrans. Now, how does it produce visceral larva migrans? I will not put the life cycle for you because it does not interest us. It's a roundworm of the dog. But what happens is that if humans come to accidentally ingest the eggs of Toxocara canis deposited by infected dogs, and this is not difficult to happen. If you think of children going to picnic with their families, they would be eating a sandwich, they put it on the ground, go play for a minute or two, and then come back, have a bite from this sandwich, and repeat that again. Meanwhile, they would be catching anything from the ground as well. Babies would be crawling around in the field sometimes at picnics and eating anything, whatever. Well, those eggs can be ingested by humans, and if ingested, what happens? The larvae will hatch out and they penetrate the intestinal mucosa and wall, but they don't know how to find the blood vessel. They are not like Ascaris, they are not human parasites. So they do not have the biologic capacity to find the blood vessel and go through the circulation to the lungs to molt once there and then be swallowed again. So this is a non-human parasite. What happens is that those larvae keep on migrating in the abdominal viscera. There, they would be producing abdominal pain and eosinophilia and a little bit of fever as well. Hence the entity of visceral larva migrans. So it will migrate in the viscera, in the abdomen. Those are the larvae of Toxocara canis, and they would be migrating continuously because they don't know how to find their destination, which is usually the blood vessel. And on the right hand side, what you see here, a picture in black and white, but you can easily appreciate the larva in the center of that circle actually, and that circle is made up by tiny dots, which are the darkly staining nuclei of the white BCs, and you can appreciate the high magnitude of inflammation in those areas around those larvae. Hence the entity of visceral larva migrans, which is always present in the differential diagnosis of abdominal pain, especially in children. So this is an entity to keep in mind. Visceral larva migrans by Toxocara canis. Here we have got some epidemiology that you can read. Transmission, as I told you, fecal oral route, but from the dog feces to humans. And whenever people work with the sandboxes and in parks where dogs would go frequently, and that's it. Don't worry about the production of Dipylidium caninum producing the same entity. That's rare. Clinically, as I told you, upon ingestion, larvae hatch out of the eggs and start migrating around in the abdomen, but because they are animal parasites, they cannot find their normal destination and keep on migrating around in the viscera, hence the name visceral larva migrans, associated with eosinophilia. Why the high eosinophilia? Because the larvae are migrating and they are face to face with the immune system, and the immune system reads them and produces a lot of eosinophils which help in killing of the parasite as well. Okay, so eosinophilia is an important feature. Neurolarva migrans is when a larva migrates to the central nervous system, and there it can produce neurologic deficit. This is an entity that is very well known nowadays, and we had reported on it. A large report came out from the AUBMC. We know that fairly well, and our neurologists are really fine-tuned into this entity as well. Ocular larva migrans also can occur whenever an ectopic larva reaches up to the eye, and their inflammation will develop around it, and it grows like a tumor actually. Okay, diagnosis, high eosinophilia is a feature. Serology is very helpful because we don't have eggs, we don't have anything to look for in this case. So it's eosinophilia and serology. Treatment is thiabendazole, which is an old benzoimidazole derivative, or albendazole, that can be used. We don't have thiabendazole here, so we really resort to albendazole, which has to be given at least for 5 days, sometimes for 2 weeks, depending on the cases, especially for neuro or for ocular larva migrans. Problems, control of dog and cat feces in parks and sandboxes, so they have to be disposed of in a hygienic way. Diagnosis is difficult because of non-specificity of symptoms, but this is where eosinophilia and serology can be very helpful. Cutaneous larva migrans. I think that you can guess it now. Here we have got the larvae of non-human parasites, like Ankylostoma species other than Ankylostoma duodenale, and Strongyloides species other than Strongyloides stercoralis. Those are animal parasites. So the filariform larva of those animal parasites on the ground, whenever it penetrates into the skin of humans, it does not know how to find the blood vessel and go into the circulation like the hookworms do. So what happens there is that it keeps on migrating under the skin, producing inflammation along its tracts, like you see in this picture. Now you can easily understand it, and hence the name cutaneous larva migrans. They keep on migrating under the skin, producing cutaneous larva migrans. Okay. Treatment is albendazole, ivermectin, or treating them locally like freezing with liquid nitrogen also can be used. Eosinophilia. I've been mentioning eosinophilia in my talks now so far, and eosinophilia is an interesting finding with parasites. If we start at the right hand side of the slide here, we have got low or absent eosinophilia that is less than 10%. It occurs with Enterobius, the pinworm, Ascaris, the roundworm, Trichuris, the whipworm. They all occur within the lumen, so they are not in direct contact with the intestines, with the immune system, sorry. They are not in direct contact with the immune system. Schistosoma also produces mild eosinophilia. Now, if we come to the moderate eosinophilia, this is produced by the hookworms. Why? Because they hook themselves up to the intestinal mucosa. They chew on the mucosa, so they stimulate the immune system more. Strongyloides as well. It is associated with moderate eosinophilia, 10 to 30%. Now, hydatid with a question mark, the intact hydatid cysts do not usually produce eosinophilia. But if they are disturbed, if they leak, or if they rupture, then they would produce eosinophilia, of course. And I told you before that they may rarely produce anaphylaxis, severe anaphylaxis. And then we come to very high eosinophilia. This occurs with Trichinella spiralis, trichinosis. Why? Because the larvae invade into the muscles and into the tissues, and hence very high eosinophilia. Toxocara canis, with the larvae migrating in the viscera, also very high eosinophilia. And with fasciola, with the juvenile trematode fasciola hepatica, migrating and developing, swimming in the liver, again in very high contact with the immune system, and also production of very high eosinophilia. And then now we go to Africa. I'll take a break in here, and then okay, now we go to the tissue nematodes. This is again under the tissue nematodes. We have Dracunculus medinensis and the filarial worms. We start with the Dracunculus. Just very briefly, Dracunculus medinensis is commonly called the Guinea worm, Guinea in Africa, and it's closely associated with step-in wells. Okay. Here, as you can see in the life cycle, which you are not responsible for, it's associated with the aquatic environment of the step-in wells. Now, how is that? How are the step-in wells? Here you see in this patient and in the other picture as well, this is a worm that occurs in the lower extremities. It goes down after infection to the lower extremities. And the gravid female will stick out its tail next to the skin. And in the aquatic environment, it produces a blister, and it breaks the skin of this blister to deposit the larvae in the water of the step-in well. And as people come to get the water and use the water of the well, they get it and they ingest it actually. And upon ingestion, it goes again back to the lower extremities. So you see here the mother of this child trying to extract the worm, and this is the better way to extract it. And also you can see the worm stuck out of the leg of an animal in here. Now this occurs in areas where there are step-in wells, and if you look at the picture on the right hand side, the lower part here, in desert areas they don't have springs of water, so they have got to dig out wells. They dig out the well, and they don't have the technology of the trolley actually to pull out the water from the well. So what they do is that they build a staircase down into the well, and when they want to fetch the water, they go down along the staircase, they step into the water to fill a bucket with the water and get it for use. And they drink this water actually. And the larvae would be in this water, and hence they acquire the infection, and it goes again back to the lower extremities. Like you see in those pictures, the best way to treat it is to roll it out on a wooden stick, few centimeters every day. They say that this worm can reach to several centimeters in size, maybe tens of centimeters, and the best way is to roll it on the wooden stick like you see here, better than killing it or cutting it or operating on it. and it's becoming extinct actually, because people hopefully are getting better sources of water, clean water. Now the filarial worms, here you can see in this drawing the foot of this patient is drawn like the foot of an elephant, hence elephantiasis. But how would a worm like this result in elephantiasis? Interesting. Let's see how. Now the filarial worms in the lower part of this slide are like Wuchereria bancrofti, Brugia malayi, Onchocerca volvulus, and Loa loa. There are other filarial worms which are less important. Even those we shall study them only briefly. So you see in this picture that the leg will become edematous, the leg and the foot, like an extremity of an elephant. And this is produced by the lymphatic filariasis produced by Wuchereria bancrofti and Brugia malayi. Let's see how. For those lymphatic filarial worms, the vector is the mosquito, like you see here, mosquitoes, culicines and anophilines. And you know that mosquitoes usually go for a blood meal from humans or from animals for that matter. Mosquitoes are most active at night, and this is the time when they come to bite us. And those mosquitoes can transmit the larvae of these worms into the susceptible humans, and upon the bite and deposition of the larvae under the skin, those larvae will migrate to the nearby lymphatic channel, and they come to deposit themselves and live in the lymphatic channels and in the lymph nodes. So wherever the limb is bitten, let's say, that limb will be affected. Like drawn in here, you notice that the right lower extremity of this in this drawing is swollen. Why? Because of two things. First, the presence of the parasites in the lymphatic channel there and in the lymph nodes will produce physical obstruction, but more so if there will be inflammation in those lymph nodes and lymphatics, the obstruction will become very severe, and hence there will be edema, which will result eventually in elephantiasis. So here we have some details, the mosquito and then the pathologic section that shows us within a lymph node entangled worms in there. Again, I would tell you that those are roundworms with separate sexes, and the gravid female will produce the larvae into the lymphatics, and you know that the lymphatics eventually go to the thoracic duct and join the circulation, and hence they would be present in the bloodstream. Okay, clinical manifestations. In endemic areas, most of the people would have asymptomatic microfilaremia, which means that they would have the infection, but without showing much of symptoms. No fever or low-grade fever occasionally, and no edema and no elephantiasis, of course. Then a smaller portion would have filarial fevers and lymphedema and lymphangitis and lymphadenitis, inflammation of the lymph channels and lymph nodes, and a very smaller minority actually which will produce chronic lymphatic disease with obstruction and development of elephantiasis. Now, why does this happen? It is said here that the bacteria called Wolbachia, if it comes to infect those parasites, then it will affect them, and there will be inflammation invited by those parasites, by the infection with those bacteria into the parasite, and hence the physical presence of the worms there with their inflammation, with the inflammation that they produce, will result in obstruction that results in lymphedema and chronic lymphadenitis and lymphangitis that will result in elephantiasis. So the inflammation in there, where the bacteria Wolbachia is instrumental in producing that inflammation. So the clinical complications of lymphatic filariasis is like tropical pulmonary eosinophilia, which means that infected patients may have pulmonary symptoms, usually at night, associated with eosinophilia, night after night. This is known in endemic areas only. Orchitis and epididymitis, this occurs in males where the lymphatic channels in the pelvic area would be involved and obstructed. Elephantiasis, we spoke about it, and chyluria is for breakage of a lymphatic channel into the urine, and the urine becomes turbid like milk. Diagnosis. The diagnosis is by blood smear examination, and those blood smears are better gotten at night. Why? Because here we have got synchronization between the activity of the vector, the mosquito, which is most active at night. It comes to pick up a blood meal from humans at night, and then those parasites would liberate their larvae into the lymphatics and into the bloodstream mostly at night. This is like synchronization between the vector and the parasite. Hence, we would have nocturnal periodicity like you see on this slide. With those lymphatic filariasis agents, we have nocturnal periodicity. Okay, so we examine blood smears better taken at night, as I said, to find the microfilariae, the characteristic microfilariae like you see in the upper picture in here. PCR testing is also helpful, but it is usually in academic and in research laboratories in the tropics. Radiology can be helpful to show us abnormality of the lymphatics, okay? Serology can be very helpful actually by detecting antigens or antibodies. Treatment. The treatment is with anti-inflammatory agents, so there you would start with anti-inflammatory agents, because if you give drugs that will kill the parasites, so killing the parasites may produce more inflammation and more obstruction, so you better give the anti-inflammatory, and then diethylcarbamazine, DEC, or ivermectin and albendazole can be effective. But the drug of choice here would be DEC, diethylcarbamazine. Don't worry about the details of the drugs for that matter, just for your information. Prevention, control of the mosquitoes, of course, but it is not easily done, especially in the tropics. Then like we mentioned with malaria, long-sleeved clothing to cover the skin to the best possible, screens on windows and on doors, and using insect repellents whenever out or on the exposed areas of the skin. Next, we come to Onchocerca volvulus, another filarial worm. This produces onchocerciasis, which results in river blindness. Wow, interesting. Again, how would a parasite result in blindness and river blindness? You see the statue in here, a young boy leading an older person, an old man with a stick. So the boy can see well, but the man is blind. This is for river blindness. How does it happen? Let's see. It occurs around rivers, and there the vector is the black fly. The vector of onchocerciasis is a fly which is black actually. It is hairy, and those hairs are black. It just looks black, and you shall see a picture of that. And this fly lives around rivers, and it deposits its eggs around the edge of the water, which is slowly flowing at the edge of the river, and the larvae which hatch out of the eggs attach themselves, like you see in the left lower panel. They attach themselves to vegetations in the slowly flowing waters there, and they develop as larvae into pupae, and then the pupa will hatch out into a young fly. Let's see some more about it. Onchocerciasis occurs in those areas in tropical Africa and tropical South and Central America. Okay, so it's only a tropical disease. And here in those pictures, you see that there is an African village nearby the river. And of course, the river gives it life for everything, for using the water, for irrigating the land, for washing, for bathing, for everything. And we can see on the right hand side upper picture, we can see the black larvae of the black fly in the slowly flowing waters at the edge of the river. And here is the black fly. You can see it and you can appreciate it. But this village was abandoned, like the picture of this abandoned village, because of river blindness. Now, river blindness actually is produced. This fly bites at daytime. And at daytime, it bites on the exposed areas of the skin, mostly the head and the shoulders. So at the bite site, it will deposit the larvae of the Onchocerca volvulus. And the larvae there go subcutaneously, and where they remain where they are, in the subcutaneous area. And there they will develop a nodule around them, and they will grow. Those are roundworms. They will grow into adults, male and female, and by fertilization, the larvae will be produced by the adult female, the gravid female. Now, those larvae will be deposited into the subcutaneous tissues where the parasite is living. Now, the larvae move around, and as they move around in subcutaneous tissues in the area of the head and the shoulders, they come to cross through the eyes. As they cross through the eyes, of course, they are microscopic structures. They are very tiny, very small, but by thousands of microfilariae larvae crossing through the eye, the anterior chamber, the cornea and the lens, and the posterior chamber, the retina and choroid. Upon the repeated crossing of larvae there, and day after day, there will be fibrosis resulting from the mini inflammation every day that is occurring there. Eventually, there will be opacification by fibrosis of the lens and the retina and the cornea, and all of these will be damaged by fibrosis and opacification. So hence the river blindness. So as you can see, adults there living for a long time by the river with the black fly in their environment, they will become blind. Now, clinically, we have skin nodules, onchocercal dermatitis, that is irritation of the skin, results as well. Sauda, I'll show you a picture, and blindness will result. Diagnosis is by a skin snip. You take a small piece of the skin, put it in a drop of saline, and mount it in a drop of saline on a slide. Put a cover slip and examine it under the microscope, and you can see the microfilariae. A treatment is anti-inflammatory again, and ivermectin. Ivermectin is an excellent treatment for Onchocerca volvulus. Okay, this is the way you take a skin snip. Expert people know how to do it. And over the right hand side, the upper and the lower pictures show you unstained mounts where you can see larvae in there. And again, you can see the larva in the lower panel. And to the left hand side, you have got a stained larva, which you can, upon staining, identify it and know what larva is it, what microfilaria is it. Is it the Brugia or the Wuchereria, or is it Onchocerca? Okay. Onchocerca volvulus microfilaria. And this is for Sauda. So in an affected limb, actually, what happens is that there can be hyperpigmentation, and you can see here darkening of the skin, and this refers to the Sauda. And Sauda actually comes from Arabic, because this infection occurs in some parts of Yemen and Sudan, and they call it Sauda there. So the name Sauda comes from Arabic. Sauda for the Sauda limb, actually. All right. Now we can understand how this young boy is leading the older people. They are not very old, actually, but they are older than the boy. And as I said, ivermectin treatment every 6 months gives big hopes for prevention of this infection. And here we see a helicopter spraying insecticides and other things around the river in Africa. Lastly, we come to Loa Loa, or the eye worm. God, here we have got an eye worm. Why is it so called? Because this adult worm itself, like you see in the upper picture, can cross through the conjunctiva of the eye, and it can be observed at that site. I shall show you a better picture than this one. It is transmitted by flies, again, the deer flies. They are called deer flies. This is the most important vector, but there can be different types of it. However, this deer fly is big, and it's active during the daytime, and it bites at daytime. Hence, it attacks people working in the field, like farmers. They would be sweating and feeling hot, so they take off their shirts, and then they are subject to the bite of the deer flies, which can bite rapidly to deposit the larvae microfilariae. And this fly actually is big. It's about 2 to 3 centimeters in size. It's quite big. But it manages to bite and deposit the larvae on the skin. Now, where does loiasis occur? Loa, it occurs in those areas depicted by the blue dots in here. The yellow area is for the rainforest in Central and in West Africa, but in tiny foci of those tropical forests, you have loiasis, Loa. And in the picture of the eye, over the right-hand side here, I'm sure that at the tip of the arrow you can notice that this is the beginning of a worm, and then you can follow it going rightwards and then upwards, and then you can see it clearly. There is a transparent worm crossing through the conjunctiva, hence the name of Loa. Actually, this worm lives in the subcutaneous tissues. Wherever it is deposited, it develops into an adult worm there. And it does not go to the lymphatics. It does not produce a nodule around itself to make it its home. It simply develops and keeps on migrating in the subcutaneous tissues. As it migrates, it passes through the eye, and hence it acquired the name of the eye worm. And as it migrates as well, it produces some edema or inflammation behind it. So clinically, we would have inflammation and edema called Calabar swelling, and I shall show you a picture of that. When it crosses through the conjunctiva, it may produce a little bit of conjunctivitis, redness of the eye, and you can see it, and probably you can remove it then. It can be extracted from the eye. Diagnosis is by excision of the adult worm from the eye. Of course, it can be done. And the day blood examination for microfilariae and eosinophilia also can be a clue. But here we have got the blood samples have to be taken at daytime. The best time probably for it would be around noontime, because it has got diurnal periodicity. The vector, which is the fly, is most active at daytime, and the larvae are usually deposited at daytime. So there is synchronization between the vector and the parasite, and that is the time to get the blood sample for examination. Now, why do you get it like that? Because you would suspect Loa, and you look for it. This is the way you look for it to diagnose it. Treatment: diethyl carbamazine and steroids as anti-inflammatories. This is for the Calabar swelling. You notice the arms of this gentleman to the left side. This patient, the arrow points to the swollen forearm in this man. This is for Calabar swelling. Over the right-hand side, you can notice a swollen knee in there. And in the upper picture, this is a European tourist with severe inflammation, I would say, as we can see from the redness and from the swelling around the eye. This is for Calabar swelling. At one time, I had the experience of getting a patient or more than a patient telling me about swelling that migrates from here to there, and they are coming from Africa. And I tell them that this is most probably Loa, and go back to where you come from, and they are more expert than me in treating it. Now, we have been mentioning microfilariae and larvae of those filarial worms. So, how can we distinguish between them? Upon staining, we can look at the characteristics of those larvae, if they are sheathed, that is, if they have got an envelope around them or no envelope. And we can look at the stained nuclei as well. If you look here, Wuchereria bancrofti, the nuclei don't reach to the tip of the tail. There is a space without nuclei there. Whereas in Brugia malayi, two nuclei, they reach to the tip in tandem, yani one after the other like that. You can see it easily on the microscope. And in Loa, the nuclei do reach to the tip of the tail, and they are all sheathed, of course, but Wuchereria and Brugia have got nocturnal periodicity. You find them at night, whereas Loa, you find it in daytime samples of blood. Again, the same thing as I'm telling you, so parasitologists can easily identify them, and we can see the filaria, the larva the microfilaria of Onchocerca volvulus, the right lower cornel. The nuclei do not reach to the tip, but also it is non-sheathed as well. And if we go to the cephalic part, the head part of the microfilariae, again there are distinguishing features which are not of interest to us. Management diagnosis is by finding the microfilariae in the daytime samples, as we said. Surgical removal from the eye, okay. Chemotherapy, DEC, steroids, control of deer flies, but this is difficult in the open and wide breeding areas. This is at extraction of the eye worm. This is just for your review. You can look at it, and next time we shall study